right, welcome everybody. Back from the break. Looks like we're still waiting for a couple of folks to come back. Hopefully I didn't scare anybody off. I said I would do karaoke, but I thought that would bring people in, but I guess it did the opposite. So just like Fern said, quick introduction about myself. I actually used to be the director of BI and analytics at Qualcomm. Qualcomm's that giant company in San Diego. It is not the stadium. I do not work for the stadium. I never actually have ever even been to the stadium. It's a large semiconductor in San Diego. I mean, all the technology in your cell phones is based on Qualcomm technology. So I did that for about half my career, managed a lot of different platforms, worked with thousands of different use cases, lots of different business users. I worked on the IT side for a little bit, switched over to the business side, and went back and forth about 10 or 15 times throughout that transition. And then before that, I worked for Accenture, which is a very large, expensive consulting firm that some of you may have worked with. I apologize if you do work with them. I have nothing to do with their prices. But I did that for the first part of my career, again, focused on analytics, working within electronic media and high tech. So about 4 years ago, I started my company, Analytica. It's not analytical, it's Analytica. We took the L off. So my company focuses primarily on all things data, so data visualization, data governance, analytics, both on the descriptive and prescriptive and predictive side. And we work with lots of agencies throughout the state of California. We're very geographically based. We've got 2 offices. One is our headquarters in San Diego. We work with a lot of the biotech companies there, healthcare institutions like UCSD Health, Rady Children's Hospital, AMN Healthcare, biotech companies like Illumina, which decodes all the genomes of everybody on the planet. And we also have a strong presence in Orange County. We work with some of our clients there in the biotech space, like Edwards Life Sciences. And then our office up north in Sacramento primarily deals with our state agencies, so California Department of Public Health, Franchise Tax Board, which is my favorite client because I actually get to have a little bit of that money back that I pay in taxes, so they're one of my favorites. And today, I'm going to walk you through a couple things. I'm going to basically take you through a quick predictive analytics background. I know that we've talked a lot about that today. I joined a little late, so I unfortunately missed some of the presentations this morning. But I'm going to give you some introduction about what predictive analytics is, how it's used within healthcare, and then some of the challenges that I'm going to talk about. So I'm not going to focus too much on the fancy algorithms that our company uses to do predictions. I feel like that's almost a commodity now. I'm going to really talk about the challenges of how to deploy that, right? We hear about a lot of use cases in the industry where, hey, I found this great algorithm Netflix is using to predict exactly what you're going to watch and when you're going to watch it. And those are all wonderful use cases in tech. But in healthcare, we're talking about an industry that goes about 10 to 15 years behind any technology industry. So they're pretty far behind. So it's really challenging introducing even descriptive analytics in an industry like that, let alone predictive. So I'll talk through some of the challenges that we had to overcome. So someone mentioned this earlier in the panel, and I apologize if this is a trite slide and you've heard it before, but there is that 80-20 rule when it comes to predictive analytics, right? Data scientists spend most of their time dealing with the issues of data, right? They only spend 20% of their time actually doing the fun stuff. And it's kind of like when you're raising a kid, right? When you're a parent, you kind of live 80% in that parent syndrome of go brush your teeth, eat your carrots, and do all those things you try to have your kids to do. And 20% in the fun, which is, hey, let's play hide and seek and tag and all those fun things that you want to do with me. And data scientists face the same exact problem, right? And this has been an issue since the beginning, and it's especially prevalent when it comes to the healthcare space. So a lot of the healthcare agencies that we work with that are more technology driven than some of the others, they see this problem, and it's a very difficult issue. And I feel like there's 3 ways to solve it, right? The first, which is very obvious, is technology, right? So there's lots of tools out there that you can arm your data scientists with. There's R, there's programming languages like Python, there's SPSS, there's SAS, there's JUMP, there's tons of solutions out there for them to do their modeling and even some of their data prep. But I think that the next 2 things are issues or are areas that often get overlooked, right? The first is data. So you want to make sure that you give your data scientists clean, accurate, reusable data sets, right? The worst thing that you could ever have, especially in healthcare, because healthcare is so cost suppressed is have redundancy and inefficiencies, right? Have a data scientist in an organization in X do the same thing that the organization Y did, and they both present it to the CMO or someone that's leading the hospital. The numbers are incorrect, or they've both reproduced the same exact data set, and nobody really wins, and it affects lives and it affects outcomes. The third thing that often gets overlooked, which I heard someone say on the panel earlier, is you have to solve this with people. I firmly believe that you need some kind of centralized data team. This can take on many different names, and I've got a whole slide on this, but you need a team of people that's in the enterprise. They can be in IT, they can be in the business, someone that's centrally governed, where they work with the data scientists providing different things. So they're giving them training sessions on how to use the right tools. They're looking at their data sets and trying to make them more enterprise grade or enterprise ready, right? They're holding office hours where the data scientists can come in with a challenge that they're facing with manipulating some of the data or creating a model that they're getting stuck on. You need the support of this group, and you need that created in the organization so that it can help all the scientists throughout that particular industry. So show of hands, who actually does predictive modeling here? Who's like hands-on, develops in R, SAS, or some of the others? Okay, so only a few people. Okay, good. So this is the predictive modeling workflow. I think if you Google this, you'll see this. It's everywhere. And essentially, you'll see that there's a series of steps. The first is you have to gain business understanding of your data, right? One of the core pillars of a good data scientist is they have domain expertise. So whenever we take on a project, for example, in the biotech space, I'll put my consultants that have biotech experience on that particular engagement, because the worst thing is I give them someone that's very finance heavy and we're doing genome statistics or genome analytics, right? It's just something that that person needs to have a business background, a business understanding in. So first is to get that business understanding, and then there's data acquisition, which is actually a very difficult thing to do, right? In organizations where you don't have data warehouses, and in the healthcare industry, there aren't a lot of data warehouses. Things are in files, things are on paper. It's very, very far behind. That data acquisition step is very difficult to achieve, so the scientists are spending a lot of time just trying to acquire that information and getting into one place. And then the vicious cycle begins, right? You need to explore that data, take a look at how to join it, figure out the inconsistencies, where the data quality issues reside, how to fill in the gaps, right? And then you need to prepare that data. You need to join it and transform it and clean it. Then you start doing the fun stuff, right? So you start building your models. You use regression models, you use neural networks, all those fun things that data scientists finally get to do, they get to do at that step. And then they evaluate it. They see how it works. They look at their outcomes. And then they rinse and repeat this. Usually I've seen 10 to 20 times to get a good model going, right? You're not going to get it on the first step. And then you finally deploy, which is a very difficult exercise, because now you've taken this science project on someone's desktop or on AWS, and now it needs to be operational on files and paper-based data. How do you do that? That's insane. So this is the workflow, and this kind of goes back to the 80-20 rule, and you'll see that most of the time that's spent is in that data prep phase, and only 20% in the modeling. So let me introduce the case study. I unfortunately was not allowed to mention the agency, but it's a state public health agency, and there's a giant map of California right there, so you can probably figure out which state public health agency it is. So this is one of our premier clients in Sacramento. We've been working with them for about 4 years now. The mission of this agency is to improve patient care and quality throughout the state, right? So this is the agency that all the facilities, so facilities, I mean hospitals, labs, they register with the state. They actually get a license to operate as a hospital or facility. This is the agency that audits all those facilities to make sure that the healthcare quality is up to par. This is the agency that has programs to teach women, how to breastfeed and take care of infants to improve quality of life for women and children. There's lots of different things that this agency does that are very important to improving the healthcare of the particular state that I'm talking about, which if you haven't figured out yet is California. And it's a giant agency. It's got 200 programs, right? 6 centers, 14 offices, 10 divisions. It's actually the largest public health agency in the world, right? It's bigger than the UK. It's gigantic. And it has one of the biggest data problems I've ever seen in my career. And the reason is because data is all over the place, right? There is no central office to manage the data. You've got epidemiologists in all facets of the organization doing their science experiments and not talking to one another. So many silos, so much data from various levels throughout the government, city, local, county, state, federal. All these systems need to get integrated, and there's no way for them to talk to each other. So we have to figure out how to connect all this spaghetti together. So the solution that we first came in there with is, they wanted to do predictive analytics. They're like, Steve, can you come and make us more data-driven, and let's start doing more predictive analytics for the organization. We really want to get ahead of some of these problems like the opioid crisis or improving healthcare-associated infections so that we could predict when a MRSA outbreak is going to occur. How do we do that? We've got all this data, but we just can't make it work. I said, well, let's take this approach. First, let's make sure that you've got the right technology. So we did an assessment of that. Then let's talk about putting people on this, because you're going to need people to work with all your epidemiologists and data scientists. And then the biggest problem you're going to have is getting an executive buy-in, right? The executives of this agency are, like the governor of California, and and the people underneath him, and the people that run the agency. These aren't technical people by any stretch. These are policymakers, physicians, and they speak in different languages than we do. So we have to try to get their buy-in and get their trust. So I'll talk about how we did that. So let's start with the technology footprint. So when we first came in, technology-wise, they actually spend quite a bit on technology because they were very focused on solving their problem when it came to descriptive and predictive analytics with technology. They had tons of SaaS licenses throughout the organization, tons of R licenses, plenty of Microsoft SQL Server and the Microsoft stack to do that entire BI layer, tons of Excel, as you can imagine, lots of files. So the only thing that we were really able to add was we noticed that they didn't really have any standardized data transformation capabilities. So the blue areas are essentially where we focused. So we did an assessment. We made a lot of recommendations, and I'll talk about which ones we picked in the next slide. So we really took that problem and tried to solve that for them enterprise-wide, and we took on one center at a time to see how it would work out in that particular agency. And then we kind of went back to the drawing board when we saw that one particular technology didn't work, so we selected another. And then we noticed that they'd greatly benefit from some kind of data science platform. So I'll talk about, they haven't selected one yet, but I'll talk about the ones that we've proposed. And then the other thing they were missing was a good visualization tool. So a lot of the folks up in the north, they love Tableau, and the state agencies, they love using it. So we recommended that as a solution for a lot of their visualization capabilities. And they were able to stand up a Tableau server with our help and start visualizing a lot of things in Tableau and integrating it with what they were doing in R and trying to integrate that with SAS as well. And then they were very crazy about everything going into SharePoint. Don't ask me why, but we did a lot of integrations to get that user interface working in SharePoint, both publicly and internally. So I'll talk about how we did that. And feel free to stop me. This is very interactive. If you have questions, raise your hand, and I can answer them. So the data transformation types, again, this was a huge education thing for them. They didn't know what data transformation was. So we had to basically go back to the drawing board and explain what Informatica is, how it's used. And it's crazy to watch an organization skip the BI that we know of over the last 20 years and go right from that to doing predictive modeling. So we educated them in the 3 different types, and you guys all know this. You're all technical, or at least in the industry. So there's data integration. Think of this more of building a data warehouse. This is like true ETL using tools like Informatica, Microsoft, SAP, IBM. Then there's data virtualization. This is one of my favorites. This is almost like you're building logical data warehouses where you're storing that transformation, but you're not doing any movement of the data. And then there's self-service data prep, which someone talked about earlier, which is tools that make it really easy for data scientists to do that ETL on their own, right? So it's like Informatica for a data scientist. And there's lots of tools in that arena like Paxata, Trifacta, Dremio. So we started with the data integration route for them, and I knew it would fail. And we went through one center, and we tried to stand up a bunch of SSIS packages with SQL Server, and it was just so much overhead for them to manage that and for us to help them with that. We kind of skipped and went right to the data virtualization use case pretty quickly, and we're standing up different data virtualization solutions for some of their centers because that seems to work a lot better because their data is just so disparate. Just moving that information from one network to the other is so complicated with so many rules within the government and security that it's just impossible to move that information. So virtualization works really well. And then we're also talking about giving the data analysts a self-service data prep solution. But I'm not the biggest fan of those types of solutions because I feel like they create too many silos. I want something that both the IT and the business can kind of play in rather than just one plays in it and the other one sits on the sidelines. So data virtualization is one of my favorite patterns, and I like that. And then in terms of the platform, so is anybody familiar with SageMaker or Domino? Show of hands. Yes? No? Natasha? The only one? OK. So there's platforms out there for data scientists, and they're almost like these solutions where they can upload their code and create shareable models, right? And it gives you lots of things. So it gives you code reuse. It gives you processing power. So you can run a model in the cloud and select your virtual machine and then watch it run without getting IT involved. It's a way for you to share a really great R script that you wrote. It's a way for you to centralize a lot of your development in one place, right? So essentially, if you think of, if any of you were software architects like I was back in the day, I mean, this is like, SourceSafe. It's a very great version of SourceSafe for your data scientists. And I think that, organizations that have a lot of scattered development would benefit from this because just because someone's writing a model for a marketing use case doesn't mean that that model can be reapplied for a finance use case. There's a lot of crossover that can get used. And it's great to have a visual into the data that they're actually analyzing. And these platforms really help you see that. So I'm a huge fan of them. So we're standing up one of the two. So we're down to SageMaker or Domino. SageMaker is the Amazon product. Domino is kind of its own company that just focuses on this. They're out of the Bay Area. So we're going to pick one of the two. But this is going to be a great benefit for them. And then the next thing that we did a technology assessment. Like I said, we helped them with the integration. We stood up where we're going to be standing up a data science platform. Now let's talk about what we did in terms of organizational change, right? So right here, there's a little diagram that shows you this big blue bubble. I call it the centralized data team. They actually renamed it to the Analytics Services Unit because they have to have unit in everything in all their titles. So the purpose of this team is what I was talking about earlier. This is a group of individuals that are technical and have a good understanding of the various public health policies and programs. And their purpose is to help the data scientists on their journey on any of these predictive modeling use cases. So they'll sit there and train them on Tableau, or they'll help them get their R script into an operational mode, or they, maybe one of the epidemiologists is kind of stuck on a public health analysis. Analyzing MRSA, so maybe a person in this team has done something similar to that in the past, and they'll help them figure out the right variables to do that analysis. So that team is really important, and the way that we structured it is it actually doesn't report in IT. It reports to a center, and again, this is a state agency, so think of a center like a business unit. It reports in a center that reports to the director. So it's got very high visibility. We had to have director buy-in, so director is like the CEO. We had to have director buy-in of this team because we were able to basically show that there's all these different projects that are happening and none of them are being successful because when we presented them to the director, she never heard of them. So the reason she never heard of them is because none of them were successful. And the only way you can make these things successful is by arming these people with the right individuals that can help them get their project over the line. So that's what this team does. And this team works with all the centers. And then another thing that really helps this team is to have a person or a group of people from each center or business unit be their liaison. And that person or group, they understand everything that's happening in the center or the business unit. They know about all the projects, and they're meeting constantly to get to that, to that end goal of developing these enterprise data assets and getting these really good models out there. So that's why you see the crossover right there between each individual one. And that's very important. So I think this is a thing that's often overlooked. I don't hear a lot of people talking about this. The reason why I always bring this up is, when I was at Qualcomm, this is something that I created, and I felt like it was incredibly successful. We had a pretty large self-service analytics offering that we were able to stand up. We had about 15,000 users that were looking at all the dashboards and doing their analysis. And we had 400 developers that were building 4,000 dashboards and models and you name it. So those people all needed someone to go to whenever they got stuck. And, and it was very important to have that. And I feel like that's the reason we had our growth at Qualcomm. And that's what we're doing with a lot of our clients and helping them create this organizational structure and arming that team until they can find the right resources internally to own that and take it over from us. So once we got that in place, almost at the same time, we really were focusing on getting the executive buy-in, right? And we knew that, we were working with the CIO at the time. We knew that if we went to the director and said, hey, we want to build this and we want to buy these technologies, right? The data transformation tool, we want to stand up a team, we knew that she'd never go for it. We need to have some wins, right? So what did we do at the same time during all this? So here's a win that we put out there. So there's a unit within the Center for Healthcare Quality that basically is responsible, like I said earlier, for collecting all of the licenses of all the facilities throughout the state. So a facility is a hospital or a lab. And they collect the fees for that license, and then they also audit those hospitals, a very important job that they function, right? So every time you go to the hospital, you know that you're going to a top-notch institution because it's audited by this particular agency. So one of the things this agency wanted to do was take a look at all the complaints that were received and then figure out what can we do with those complaints. Can we better describe what's happening at certain hospitals? Can we audit them faster? Can we collect on fines? Can we improve the quality of some of our community hospitals? Lots of use cases, lots of different data, and it all needed to be visualized at 3 different levels. It needed to be visualized in the capital by the central agency. It needed to be visualized by all the district offices, and it needed to be visualized by the public. So we're talking about PHI information that needed to be dumbed down for the public and then shown to the district office for their particular office, and then shown about every patient to the central office. So we solved this. We created this great solution. We put Tableau on top of it. We did a lot of excellent data integration. And we got this thing to work, and it's actually live. I don't have a link in this, but I'll send it to Fern. She can send it to all of you, and you could all actually take a look at it. And it's really important information. It shows you down to the, almost down to the hospital, how many complaints were received in the hospitals near you, and what those complaints were, and what the issues were. And this information was incredibly useful. And this is how we got the buy-in. We were able to find this descriptive use case. We were able to visualize it, integrate all these data sources from the state and the federal systems. And then we presented this to the director. We're like, look what we did. This is out in the public. It's got like 20,000 views every day. And all the district offices are improving their operations with complaints. And we're reducing our audits. And everything's more efficient. Let's take the next step. And she's like, what's the next step? And I said, it's this. Let's go predictive. Right? We saw all the complaints that are happening. We know every single complaint that occurred at every single facility, why it occurred, when it occurred, what it was. Wouldn't it be great to send the auditors to, let's say, UCSD Health? I hope no one's from UCSD Health here. I'm just picking out a name. And if they're going to look at a particular complaint, wouldn't it be great to do some very basic market basket analysis and say, OK, if they're looking at MRSA, why not look at central line infusion issues with infections that happen with central lines, right? Why take 2 trips, or why miss it? And her eyes lit up because now she understood this is something. We got the buy-in from the descriptive level. We found the simplest use case we could possibly find. And again, market basket analysis, to any data scientist, they scoff at it. They're like, oh, that's child's play. But you have to start very, very simple. You have to start something that's very understandable. And we were able to get the buy-in from this particular use case, and this improved their audits tremendously. So it's interesting from our perspective because I've got clients that are actual hospitals like Rady Children's and UCSD Health, and I work with this state agency. And both of them complain that there's too many audits. And I always say the same thing. I'm like, well, the reason is because you're just sending people on a schedule. It's not data-driven. And this actually reduced their audits by 30% in the first year. And can you think of all that tax dollar savings that occurred by not sending your auditors blindly once a month or once a quarter? Now they're going when there's an issue, and then they're finding related issues. I mean, this is a wonderful thing. So this was, again, very simple for folks that don't know how market basket analysis works. You have a likelihood of something happening and then the related things that happen based on that likelihood. And the reason why it's called market basket is you can relate it to when you go food shopping. So for example, if you're going to buy milk, you're 71% chance more likely of buying bread along with that milk. Eggs are 43%, and toilet paper is 29%. In my house, it's milk, diapers, and formula. So it's a little different for me, but generally it's following this trend. And the same thing happened with these complaints. We found that, like I said earlier with that example of MRSA, MRSA is an infection. It's bacterial. So there's going to be other types of infections if they have MRSA outbreaks there. It's not going to be just MRSA. So, we wanted to look at different variables. The ones that I have there actually showed you the variables that worked the most. So things surprised us, like staffing levels at the facility. It seems obvious, but obviously if they're understaffed, there's going to be more problems. Previous complaints and violations, very obvious. Number of patients, again, you're going to have more issues with more patients. And then the facility type. Facility type meaning, if it's a hospital in a city versus a hospital in a community, unfortunately, you'll see more issues in the community setting versus the city setting. So this is a great use case. It was wonderful. We got executive buy-in at this point, and then we started going further. So here's one that we're working on right now. And this is actually a map that you can look at. I believe that's the link right there. And again, it gives away the agency that I'm talking about. So healthcare-associated infections, what those are is, let's say you go to the hospital and you're getting a lump removed from your neck. And it's a very minor inpatient surgery. You walk out with a MRSA infection. Doesn't that suck, right? That's what a healthcare-associated infection is. You went into the hospital with one particular problem, you come out with a new problem, right? And this is focusing more on the infections. So one of the things that we needed to do was, once we obtained that trust and we had that market basket analysis working really well, then we're like, all right, let's unleash the power of our models and let's do something crazy. Let's look at the patterns to see if we can predict when these infections are going to occur and stop them. Wouldn't that be amazing? So this is something that we're looking at right now. We're doing some, it's not too complex. It's, very straightforward regression analysis to see, what occurs and then, some likelihood comparisons. But basically, the whole point is to send a message to the hospital saying, look, you've had these issues occurring. You're about to have this other problem in your OR in this particular suite with this particular physician. That's what we want to get to. And we've got all the data and the information to do it. And the executive buy-in, everything, all the hard things are now solved. Now comes the easy job, right? And that's why I want to highlight that you have to solve that organizational and executive buy-in in order to do any of this. Because a lot of organizations that I work with, that anyone works with, if you go outside tech like Facebook and Google, is executives feel like predictive analytics is science fiction. And unless you can make them understand how it works and trust it, you're never going to sell somebody on a use case like this that's a VP or above or in a C-suite. They just won't believe you, right? And the only way to do it is to do something that they understand. So that's the steps that we basically went through. So this is a really great project. We're about 75% of the way there. We're actually piloting it in the central California. You guys know I've already kind of given it away, but we're piloting it in the central California area within that district, more focused around the Sacramento region, and then we're going to go move it to the Central Valley. We're going to try that out, and then we're going to hit the big cities and then see how it performs there. And again, it's that model iteration that I talked about. We've gone through about 10 iterations already. We're going to probably go through about 50 or 60 more till we get it right. And it's going to change by geography because there's a lot of different aspects and variables that come into a prediction like this. The next project that we're working on once this is done is we're trying to work on solving the opioid epidemic. As you all know, there's a lot of abuse with prescription drugs out there. And this is a very scary statistic that in 2015, again, this was 3 years ago, 2 million Americans, which is a lot of people, had a substance abuse problem because they were using prescription pain relievers. So our doctors are the best drug dealers in the world in the US, and this is a huge problem. And for example, a personal story, I had a dental procedure done, and I wasn't in that much pain, but my dentist is like, here, take this narcotic, take that narcotic, take this narcotic. And I was like, geez, man, give me some Advil, I'll be fine. Or a shot of tequila will knock it right out. So there's a huge abuse of prescription drugs. And this is a very difficult problem to solve because it's a problem at every single level in the healthcare institution. It's a problem at the physician level. It's a problem at the at the pharmaceutical level. It's a problem at the actual pharmacy level. There's so many broken issues here that it's almost impossible to solve. So one area that we're working on is we've got this grant that our client was able to get with the CDC. And it wasn't that much money. I think it was maybe $3 or $4 million to see what we could do, right? And it was very data focused. And the whole point of that grant is to create this thing called OHAN, which is a really interesting name, but it's an opioid health alert network. And the purpose of this network is to integrate data from various different agencies. You've got the EMRs, you've got pharmacies, you've got physician, you've got hospital data, all needs to get integrated, so that we could better understand what are the risk factors to help prevent someone from being prescribed something so that they don't develop this issue, right? Something that can pop up in the EMR when a physician's about to prescribe an opioid and say, hey, based on his profile, you may want to not do this, or you may want to limit it to 5 pills, or you may want to provide something else. So we're trying to get inserted at that level, and we really want to help figure out what are the factors so that we can get ourselves inserted at that level and help prevent some of these issues. And this is a project that's going to go on for about 3 years. So the first step of this is like any project, it's going to be a lot of data prep and figuring out how do we integrate all that ridiculous, complex information that's not supposed to be integrated. And then once we do that, then the fun starts of figuring out what are the variables of a person's persona that can help them understand why they would be addicted to one drug versus another, right? So there's a lot of obvious things here, but there's a lot of not so obvious ones. And every single one of these affects a life. It's a wonderful project, and we can't wait to start working on it. So I talked a lot about the different things that need to get involved with any predictive project, right? And I feel like the hardest thing to solve, and I think a few folks mentioned it earlier, is executive buy-in, right? The typical profile, and I'm a data person, the typical profile of an executive is someone who is, their 40s, 50s plus. They didn't grow up with cell phones like me. They feel like it's science fiction. So how do you convince that person that you're not doing science fiction? And I feel like the best way to do that is to really focus not so much on pretty slides and strategies, but get your hands dirty, get a use case or 2 or 3 or 20 out there. Focus maybe more on the descriptive side of, hey, let's look at what happened, and then try to insert a predictive use case that's very, very simple so that they can tangibly understand it and maybe give you a chance to do it. And then that's your one chance. So we had one chance with our market basket analysis. If that was wrong, they would never trust us again. Thank God that that was right, and we were able to continue and start doing these wonderful things. So, I feel like if there's one thing that you're going to take away from my presentation, it's this. Because this is something that I suffered a lot when I was at Qualcomm running the BI division and analytics division there. We just, it took us a really long time to get up to the C-suite to make them understand what we're doing, because all the little projects that were happening in the organizations are wonderful success stories, but there's nothing bigger than a success story for your C-suite, because that's really what saves lives in this case, or lots of revenue or lost expenses in another case. So in summary, I talked about the data scientist problem, that most data scientists spend 80% of their time, unfortunately, doing the boring, mundane task of preparing data and getting it ready for their models. 20% is fun. And I highly recommend on any predictive analytics journey that you take that you don't skip the descriptive side and try to get something out there that kind of shows the history of what happened and getting buy-in through that. Focus on making it operational. Data scientists and these projects that data scientists work on, they're very, they're science projects, right? And you kind of tend to forget, how do we make this is wonderful, you predicted this, but how do we constantly keep predicting it? That's always a very difficult thing to do. And then you have to find use cases of very strong outcomes, right? If you're going to go to an organization or in your organization try to sell something like this, you have to be pretty sure that you're going to be able to make it work, and then the business case is very easily understood and measurable. And then, like I said earlier, the hardest challenge is always going to be that executive, right, that's going to shoot down your project or kind of disagree with your approach. You have to be able to sell them and change their mind so that you can continue, because if you don't have that, you're just going to spin your wheels. So I'll leave it to any questions if you guys have any.
Are there any questions?
So on your first use case, how much data were you dealing with? You said SQL Server, spreadsheets, and it's all over the place, right? So the data collection itself, how big was it?
I mean, it wasn't too big. We're not dealing with, machine data, right?
Okay.
So it's complaints. Yeah. So think about there's, 10,000 hospitals throughout California, or facilities. Again, it could be lab types, and there's maybe hundreds of complaints, so it's not a huge data set. It wasn't really a big data problem with them, and they don't really generate a lot of information because it's people-driven information. So even the opioid crisis use case, that's not going to be an incredible amount of data, at least from my perspective, right? Because we deal with other clients where it's very machine data focused, so it wasn't too large. I think the biggest challenge was just the integration, just trying to get it to work when you've got an EMR from UCSD connected to an EMR from Scripps in the same city. You were talking, that's a massive problem to figure out how to integrate, but it's not too much data.
Did you use any OCR technology if it was on a paper or
PDF?
PDF?
Yeah, we did. So there's Adobe, they use the Adobe suite, so we helped with that because a lot of the auditors would show up with a clipboard. Mm-hmm. Some of them actually had iPads. I would say 20% were iPads, 80% it was paper, so we had to scan all of that and then try to figure out what were they saying? So there's a lot of sentiment analysis that was happening because they wouldn't always fill out the checkboxes. It would just be, I think that there is a problem here. It is a bacterial infection, right? It's like they didn't check MRSA. It would have been beautiful if they did. So there was a lot of issues with that quality that we were able to kind of work through.
And the example of SAP and SAP HANA, was that just an example in the technology stack, or did you use it?
It was SaaS. It wasn't HANA. So it was, if I go back to the stack. So
no, on the next slide.
Yeah, this is just showing you sample vendors. Yeah, so for them, it was primarily, so the data transformation layer was Microsoft, right? And then we moved them to Denodo. The data science platform, they're leaning towards Domino. They like that one a lot. And then everything else you're seeing. So it's the Microsoft stack on the database side, Tableau for visualization, R and Python for a lot of the modeling, SAS for the statistics and some of the modeling. And then SharePoint. Everything's actually in SharePoint. So all those screenshots I showed you, well, that's a cutout of it, but it's in SharePoint because they really wanted to centralize on one platform to put everything in visually.
Is there a team that's taking over, the work that you did?
Yeah, so
and
eventually.
How did that handoff look for those in the audience?
It's messy. So this was taken over eventually. It took about, I would say, 6 months. This is the descriptive use case. This dashboard and the data sources and the little marts that we built took about 6 months to hand off. And again, I think it'll go quicker on a non-state agency, a non-healthcare state agency. Again, they're 15 years back. So at some of our higher tech clients, I mean, I would say 2-3 months for something like this. The predictive side, a little bit more complex. And it's not the modeling that's difficult, it's the operational side of it. Because, again, it's not dealing with data sets that are very enterprise class. So there's a lot of tribal knowledge and how this was done to support the model. And a lot of that had to be handed over. So that usually takes a lot longer.
Any other?
Hello. I have a question about a little bit specific data cleaning issue. So this dashboard looks very good, and I believe you guys spend a lot of time doing hard work. So my question is that when I was at school, we have like a blood pressure data. And we didn't have any results until our coworkers from Germany told us like they have a different measurement for blood pressure.
Yeah.
For example, if the nurse in the hospital asks the patient to lie down, so the pressure may be lower, but if they stand up, the pressure is higher. So the data sources are not consistent from different hospitals across different countries. So in your data set, how do you like solve this problem? How do you like make sure the data source is consistent?
Yeah, there's no magic to solve it, unfortunately. It's something that, I mean, it's called like an offset in that particular scenario, right? So if someone's laying down, their blood pressure is going to be a little bit lower versus standing up. And then sometimes when you get your blood pressure taken, I don't know if you guys know, they make you sort of sit with your arm out versus arm up. So that actually changes your pressure. So yeah, there's lots of data offsets we had to do for complaints. It was a little bit more straightforward because a complaint is, you know, someone complained about the hospital or there was a complaint noticed about some kind of outbreak. So it was very, you know, descriptive, but there is offsets that we needed to measure because geographically things are going to change, right? And they're going to kind of affect some of those complaints. But yeah, I mean, that's a very difficult problem to solve. There is no technology that solves that. It's just something that, it's a common problem that all data scientists and analysts face, and it's just a matter of how do you centrally capture that so that you can manage it and maintain it. And my favorite place to do that is either in some kind of, you know, area of, you know, the warehouse where you've got like a mapping table that's sort of built that a business user can manage. There's software platforms that allow you to kind of give your users a way to, you know, add dimensions and manage those dimensions. So that's what I would recommend. The more you can offload a technical person and give it to a business person for them to manage that offset, the better the success will be. And that's what we did with this. We gave this to the actual unit, and we gave them, I mean, it was a simple solution. It was Excel and SharePoint, and we locked down the column so they couldn't change it. And they were able to just add the offsets themselves to kind of do some of these calculations appropriately.
Are there any other questions? Comments? Where? Oh.
Yeah, I was going to ask about how you were kind of embedding these reports. So is this one in particular, I see filters in there as well. This is from a spreadsheet, and it's just linked in SharePoint. Is that where the visuals are, and you're just kind of referencing those? Or
No.
is this something else, and you're just embedding?
I'll kind of go back to the stack. So it's going through this whole stack. So we've got a combination of spreadsheets, SQL Server databases, files, and then it's going into, for this particular dashboard, it was SSIS into SQL Server. And then forget the data science platform, not necessary for that descriptive use case. And then it was basically funneled into Tableau and then put almost like an iframe into SharePoint. And then for some of the predictive analytics use cases I talked about, so the healthcare-associated infection one, very similar stack. It was, that one was primarily file-based data because there isn't really any good database that tells you all the healthcare-associated infections that are happening. It's all the facilities sending information in files. So we created a nice repository for all those files to go in, and then we put Denodo on top of that because that was a little bit stronger to use than an SSIS package. And then we put, we ran an R model on that and then visualized it in Tableau.
And that's still operational?
Yeah.
Okay. Oh, okay.
So can you tell us a little bit about the, like for this project, for example, the team that you put together?
Yeah.
You said 6 months, but how many people, how many hours?
Yep. So I did have a slide on it, but let me go back to that slide that at least gives you the visual of the team. So this team started really small, and it really just, so we started with the team here working with Center for Healthcare Quality. And that's all the examples that I talked about today were Center for Healthcare Quality, right? So we had, from our side, 2 individuals, from their side, 2. And our side was more on the data science, modeling, data visualization side. Their side was more ETL and infrastructure. So we were focused mostly on the visualization and the modeling and then giving the inputs to their internal team to do the ETL. It's very expensive to come to a company like us to do ETL. It's something that you can do either internally or offshore, right? But the modeling and the visualization is the harder part where, you know, they used us for that. Then the next project that we talked about was healthcare-associated infections. So that came from this group here, which is Center for Health Statistics and Informatics. And the opioid project's going to come from them as well. And the team's going to be slightly larger. It's 6 people. It's 3 of ours, 3 of theirs. And it's a mix of, again, modelers, visualization people from our side, ETL people from their side, and then very domain-specific individuals that have very strong knowledge of some of the information. So epidemiologists that understand how healthcare-associated infections are working and how to fix that and give us the right information we need for our modeling. And then on the opioid side, same thing, very domain-specific individuals.
So the business side is them.
The business it's a combination of business and us for this, and then there's analysts in these groups that we're working with once this becomes operational for them to take it over. So the initiative is kind of reverse. It's starting here and then moving out. But in some use cases, it'll start on the inside, then move to this, and then go back.
Okay, when you said for this project, the data volume is relatively small, so I'm assuming all the ETL you created and all the data collected is just for this project, right? It's not going to be used by other teams for other purpose?
Oh, it is, yeah. So when you're looking at, in that first descriptive use case that I talked about, I mean, this kind of shows it too, but in that first descriptive use case I talked about, we collected a lot more than we needed because we knew our end goal was to do a lot more than just analyze complaints, right? So when we got into the EMR at some of these systems, we downloaded everything. And when we got into some of the state and federal databases, we just took everything. It was almost like a one-stop shop because we knew that if we don't do it now, it'll never happen later. So we integrated a lot more than we needed. For this use case, the data just for this was relatively small because we're just focused on complaints. It's not looking at too much detailed information about all the patients involved in that complaint. It was more of institution complaint, when it occurred. So very, very simple data, but we grabbed all the information we needed around that. So the patient that was involved, the provider, all the different events that happened that led up to it, because we knew we would want to do some more predictive information about it.
Okay, so you do have the roadmap in mind when you design this.
Yes.
To be reused for other purpose.
Absolutely, yeah. So this was the project that we did here actually got reused. If I bring up that slide, the one with the bubbles. So the project that we did there for the complaints got reused by the informatics group. They were looking at infant deaths, and they were trying to figure out, why we have such an infant, death mortality rate, and why California is actually one of the highest. So they were using a lot of our data and trying to figure out what factors were causing that, because again, that's complaint information. So we took a lot more than just the facility level. We took it down to the patient level, so they were able to do their analysis based on our work.
So you're thinking you might be just building a data warehouse?
It's like, the term data warehouse it's very ubiquitous, right? It's like a data catalog, right? Or data marketplace I heard today. So it's a combination of SQL Server databases, Denodo with data virtualization. It's an entire stack. It's not just one physical or series of physical databases. It's logical, it's physical, it's files, it's a combination of everything. And we put the right lineage and documentation in place so that when we hand this over, that use case could actually happen, and it did.
Okay, so if you're dealing with much larger data volume data, like machine data, will that completely change your design architecture?
Yeah, it makes it a lot more complex. Again, this is very person-driven. So person-driven data, unless it's like social media or like an event that a person does, isn't too voluminous, right? The complexity is more about, it's not about the rules and the joins and the integrations. It's more about processing. That's the biggest issue I see if you increase this volume to 50,000x what this is, and I need to produce this daily, that's a challenge, right? So that's something that that I see that would be a challenge for something like this. So you'd have to put a better infrastructure around it in terms of the tech stack that I outlined in order to fix that. But the rules and the systems and everything and the metadata, I feel like that doesn't really get more complex as the volume increases. It's more of, just churning through it so that you can get that information processed the right way and available.
So the predictive modeling workflow that you have on page 7, at least on the presentation I have, this is very similar to CRISP-DM.
It is.
I know you can cycle multiple times before you break out of the cycle and go to deployment, but is there a reason why the branching is done out of model creation and not out of evaluation?
No, I think it's just it was written and drawn a weird way. I think it should be pointed to it should point here. So you're kind of going through this process over and over and over and over and over again. And then, it kind of comes out more after you create your model and evaluation, somewhere in between there.
Right, which makes it even closer to CRISP-DM.
Yeah.
Is this what you're still using?
I mean, this is just something that I Googled late last night and threw up there. Because Fern emailed me and said I need to fill 45 minutes. So, I mean, this is the process that closely resembles what we used, right? And the one that I generally recommend. There aren't a lot of great standards out there, right? Because I feel like a lot of it is based on, the expertise of the people that are doing that particular predictive modeling and their styles, right? So, you're dealing with really strong personalities that, these are very strong science people, and they have a certain methodology that they know is going to work, so they kind of use it. And you have to be flexible when you work with individuals like that. And in my organization, I've got people that work for me that are, again, very stubborn for a certain method, and I try to kind of open their mind to try out other methodologies that would work. In the healthcare space, it's very, the methodology is pretty standard, right? When you're looking at, especially public health information, it's a lot of multivariate analysis. It's just looking at variables and what are the best variables to help predict outcome. And it's the same methodology over and over and over again. So it generally follows this principle.
Okay, thank you.
All right, we'll end it there. Thank you so much.
Yeah.
Very interesting talk.
Thank you.